Good afternoon, everyone. It's wonderful to hear all the conversations and introductions happening in the break. And I really enjoyed our first panel, and it gives me great pleasure to introduce our second. So my name's Louisa Chancellor. I'm a public health doctor by background, and I'm also a junior research fellow at the Centre for Personalised Medicine. And our second panel this afternoon is going to get into the sort of nitty-gritty. We're going to focus quite closely on the kind of current state of low carbon health and also social care, where we are now and what needs to be done next. And similar to the earlier session, we're going to have presentations from each of our panelists and then open up to the floor for questions. And we all are really keen to have open and constructive discussions. So I'm excited to hear your questions from the audience. So now it gives me great pleasure to introduce our four fantastic panellists. So we've got Dr. Søren Kudsk-Iverson, who is a consultant anaesthetist and the anaesthetic sustainability lead. And he's going to be talking about some of his personal reflections. He's not speaking on behalf of the Trust today, I should make that caveat. We've also got Dr. Sara Khalid, who's Associate Professor and Head of the Planetary Health Informatics Group here at the University of Oxford. We've got Dr. Amy Booth, who's also got a medical background and is a doctoral candidate in translational health sciences and also co-leads the fantastic sustainable healthcare course here at the University of Oxford. We've also got Dr. Pete Sudbury, who until very recently was deputy leader at the County Council and led the development of the nationally recognised outstanding programme for climate action at the County Council. So warm welcome to our fantastic panellists, and I'm really looking forward to our discussions this afternoon. So Søren, I'll hand over to you first.
Thank you. Thank you very much, and thank you again for inviting me along. I'm really excited, and what a great first panel. It was really fascinating. So I, as Louisa mentioned, I'm first and foremost a clinician, so I'm an anaesthetist working at OUH. I'm also the sustainability anaesthetic lead there. And in many ways, I'll be talking from my private work experience from that. I work as a clinician there, and therefore likely I won't have much understanding of the higher powers that sort of is shimmering in the upper echelons of OUH. But I worked there for a while. I'm also just about to start a clinical doctorate, looking at the link between surgical outcomes, climate vulnerability, and health inequity. I brought this slide along. I think this is a slide that covers pretty much all of what I think about this in many ways. So in 2020, the NHS came out with this report, which is fantastic and really a great aspirational sort of a cry for action, if you like. It's the first public health system in the world that's put down the net zero target for 2040. And it's ambitious, and it's working very much at a system level, and it's important to have that kind of aspiration. And they put it in 2020 for 2040, so that gave 20 years to get the work done, with interim target at 2032. And they gave this graph within for how to achieve it. And it shows the different paths that sort of leads to it. And I guess important for me is the blue lines that you have. And it's a bit difficult to read, but the dark blue is anaesthetics, and then the light blue is nitrous, which effectively is the anaesthetic footprint within that. And that's why we're sort of singled out as one of the specialties that can have a direct impact, and why I got this role as a anaesthetic sustainability lead. So 5 years on, where are we now? Well, we've done a lot. There's a lot that's been happening. There's been a lot of increasing action. There's been a lot of workforce increase, and I'm really pleased to see Sara here as well, who's part of a much bigger team that OUH didn't have before, focusing just on sustainability. And there's been a lot of incorporation into practice. So a lot of people are just kind of slowly embedding it, and with the recent GMC guidance last year updating, putting sustainability as a requirement in our practice, that changes things a little bit in terms of it being a requirement in a different way for people who are not so familiar with it. And of course in 22 it became a legal requirement as well, so loads of requirements here. What's not gone so well is that the focus has gone from a word of sustainability to being carbon footprint. And we've sort of honed in, and it was mentioned earlier that low carbon in itself, we sort of have certain words that we link with the broader term, but it sort of focuses our mind in on just the one thing. And it's become a bit of a distraction because within the perioperative space where I work, within anaesthetics, within surgery, it's all about how can we reduce the carbon footprint of the individual procedure? How can we reduce the carbon footprint? How can we make that blue wedge slightly smaller? And it's important, but it becomes a bit of a distraction if that's the only thing we do. So what needs doing? And I guess we come back to the graph. In light green, you have prevention and reducing health inequalities. That's the same size as anaesthetics and nitrous. And that makes no sense to me. If you can prevent the 100,000 excess deaths that we have in the UK, if you can reduce the three times increase in preventable deaths when you compare least to the most marginalised, if you can reduce down the waiting list that are 2 times more for those marginalised compared to those not, surely that's got to be more than that little wedge. And of course, we're looking at different time frames. 20 years is not a lot for preventative medicine, but it's enough to have a bigger impact. And in some ways, my worry is, and again, speaking from personal experience and my growing learning in this, is that this to a degree accepts status quo. It accepts that the waiting lists we have are as they are. It accepts the way that we manage things as they are. We can do things, we can tackle waiting lists, but we're doing it within this scheme of where we are now. And the Marmot report shows increasingly that inequality is increasing, so the numbers will only get worse. The impact for preventative medicine will only get bigger. So I guess I'll probably stop there because I think that's kind of my take on where we are and where we're going. But in many ways, we need to centre the climate vulnerability and the health inequity and link them more than anything. But yeah, I'll stop there. Thank you.
Sara, now handing over to you. Thank you.
Sure, thank you, Søren. In a way that provides me a great segue for what I'm going to talk about. But also thank you to Sara, thank you, Louise, as well. My background is in engineering. So I actually lead a group that does health data sciences. So I came in a bit nervous thinking how I can contribute to this debate, but I think Søren has sort of set the scene quite nicely, because a lot of what we are trying to do in my group and the Center for Statistics in Medicine is to look at healthcare inequities and gaps and how evidence generation can serve towards filling some of those gaps for us. So this is this idea that when we are looking at gaps and inequities, there's a lot of intersectionality. So it's good and great to be looking at an individual's, for instance, clinical history and their genetics and predispositions and so on, but taking a kind of more whole exposome approach, if you will, looking beyond that and looking at kind of things like their ethnic background, where they live, what lifestyles they've been exposed to, what environments by extension they've been exposed to, and so on. So all of that needs to be looked at if we are to really kind of look at a holistic picture of inequity and so on. And I guess the argument here is that if you can do that well and plug some of those disparities, you're not only, potentially making a case for improving patient outcomes, but obviously if you do it with efficiency, you're potentially reducing systemic waste as well in a way. So there's a kind of a dual-edged thing here about, I would say, mitigation, as well as what I call we need to keep an eye on the next thing any which way, is the inevitable sort of, we need to be planning towards some of the adaptation and so on, because, just the ONS, which publishes their heat mortality report, for example, every year, they're showing how, at least for the next 30 years, we're looking at increasing heat waves and so on. So all of that, we need to understand who's at risk, and are there disparities within that as well, and how that can, what we can do. So during the COVID-19 pandemic, I'll go back a little bit, but the idea is that the COVID-19 pandemic is where a lot of these long-standing, multifaceted sort of inequities in health were really brought to the forefront and highlighted. And one of the sort of core studies by the government at that time was to look at how do we begin to study inequity. So some of the work we did was, or what involved in this national core studies, was to really just look at the data as the first step. So what we mean by data in our kind of world is looking at observational data. So going into the healthcare systems, looking at electronic health records. In this case, looking at electronic health data for 60 million individuals from across the UK, obviously all de-identified and de-anonymized. So here the idea being that you know, in a population of over 60 million, you have more than 250 self-identified ethnicity groups. So if we are to begin to look at our population subgroups and understand sort of you know, risk profiles and those sorts of things, surely this is an important point to, you know, to bear in mind as well. Also, this study interestingly showed that there are gaps. So 1 in every 10 individuals in the UK, or you know, the GPs don't have their ethnicity record, for instance. And that's just an example, because where we see where there's missingness in one indicator, there's usually missingness in other indicators as well, usually lifestyle factors and so on. But that means that when we're studying disparities and so on, do these individuals get left out in the research? Do they get left out in the science and the evidence that is generated? And how do policymakers and practitioners then handle that deficit, that gap? So the idea being that you know, the disparities are often intersectional. They're not limited to things. I mean, they include but are not limited to things like we talked a lot about gendered inequities in the first session, so sex, ethnicities, socioeconomic status, where you live, the sorts of environments, green and blue spaces you've been exposed to, and so on. That's just one example from this work showing that if you really do need to have a good handle on the underlying data and who's in our population, who's accessing healthcare and so on, and then you can start to see, okay, for example, in COVID-19 mortality, what was the disproportionality? What were the gaps? Which ethnic group, for instance, in this case, were, you know, disproportionately at higher risk? And by extension, you can make that argument would apply to, you know, further research as well as we go on to look at the climate impacts of things like heat waves and floods and so on, people access to air conditioning or without access to air conditioning and so on. So really, that role of data here. And I think that's just a further point to say that once you have you know, granular data, good data, you can kind of go on to build tailored tools for, you know, at-risk groups. So in this case, kind of clinical risk prediction models, for instance, based on machine learning and so on, that can kind of look at risk factors for a certain population subgroup, which may not be the same as another. So risk estimation models that doctors use in the clinics for, you know, individuals with white ethnicity may not be suitable for application to, you know, individuals from population groups of color and so on. And that's where the idea that, you know, if you have better data at the ground level, it can lead to better research and ultimately better care for everyone. And obviously, this is all regards to patient and health outcomes. But I just want to kind of give a little bit of a flavor of what happens when we start to include what do we mean by wider determinants of health. So this, of course, is some work from the US, but what the idea here is that, and as I was saying earlier, the onset of sort of heat-related illness, the incidence of heat-related illness is just increasing globally as well as in the global north. And by including information on socio-demographics, socio-demographic differences, and so on, you can start to potentially build a better picture of what do our patient profiles look like, who is most at, you know, who are the people who are more at risk, what are the areas that need targeting, what are the locations, the geographies, and so on, all with a way to kind of informing public health guidance and practices with a view towards efficiency and so on as well. And we're extending now this work to doing it in the UK as well, and some countries in Europe as well. And I'm going to finish with this slide, but just to round off the point about the importance of looking at a holistic picture, a whole ecosystems approach, some will call it, we call it wider determinants of health. So this is a cohort of some 1.6 million children from Spain. And by linking their data to their health records, obviously de-identified data, to information captured from satellites, it's been possible to follow them as they move around and grow up from their childhood years into adolescence. So children who are relocating. Obviously, you cannot randomize children into a trial on climate. So this was the closest we could do to try and understand what are the impacts of environmental degradation. For instance, if you move from a good environment or healthy environment to worse environments, what impact can that have on children's health? So here we see that it's a kind of a natural proxy experiment, but we see that children who were initially exposed to areas of greater socioeconomic deprivation, air pollution, lived in more urban spaces, and had sort of more foreign nationalities in this case, not only was their baseline risk of things like childhood obesity higher, but those were the same children who were also at a greater risk of moving to areas of greater deprivation, greater air pollution, and had poor health outcomes. So I'm going to rest my case here, but just to make the point that maybe the idea is that when we're looking at planning for the future, planning for low carbon futures, and there was a question earlier on the first session, how do we go about talking about solving inequities and so on? So that'd be the role, a potential role for data and evidence generation there. But with that, I think I'll hand that back to Louise. Thank you.
I don't have any slides, so yeah, cool. You can just look at me. Great. So, so I'm going to be speaking about healthcare supply chain. So Søren mentioned quite rightly that the NHS has a commitment to reach net zero by 2040. That includes just those emissions within the NHS's control. But we know that about 62% of emissions comes from the NHS's supply chain. And so it has a target to reach net zero across its value chain by 2045. Now, when we speak about supply chains, what do we mean? We mean that paracetamol that you're using, those syringes that you're using, the food that we give to patients in hospitals, every resource that we use in healthcare settings comes from our supply chain. So we're talking pharmaceutical companies, medical device companies, agriculture, food industry, etc. So it's a massive scope. Now, across those supply chains, there is an environmental impact, from the raw material extraction to the manufacturing, packaging, distribution, use of the products, disposal of the products. I mentioned carbon footprint, that's about 62% in the UK. If you look globally, that carbon footprint is around 71%, so it's massive. But we need to look beyond carbon footprint as well. So let's think about waste. All of the plastic that we're using in our single-use devices, the raw materials, the biodiversity that we're using to produce pharmaceuticals, because we know about 75% of our drugs are derived from natural resources. We also, I'm not sure how many of you have heard of the case of the horseshoe crab, for example, that's used in pharmaceuticals. So we are absolutely wreaking havoc on horseshoe crab populations because we use their blood to weed out problematic substances in our vaccines, for example. So across those supply chains, there's a massive environmental impact. Obviously, it's quite difficult to reduce that impact. Why? So firstly, the NHS procures about 600,000 products from about 80,000 suppliers. So that's a massive scope. It's complex, it's global. Some of these companies operate in regions where there is very poor environmental regulation, so it's challenging to ask them to reduce those impacts as well. There's issues around transparency, so if the NHS wants data from some of these suppliers to hit hotspots and implement strategies, often that data is missing. And a lot of this is actually outside of the control, to an extent, and I'll get to that in a bit, of the NHS. So, and I mean, we can also bring in the argument of profit and money as well, that Lawrence touched on quite nicely in the previous panel as well. But outside of that, there are huge challenges to the NHS reducing their supply chain impact. However, there are things happening. And so what are some of the opportunities and actions in this space? So at a health system level, as Søren mentioned really well, prevention and health promotion is going to be key to reducing this. If we don't use pharmaceuticals that we don't need to, if we don't use single-use products, but we switch to reusable, we're not going to need manufacturers to manufacture them as much, and therefore we'll be able to reduce those supply chain emissions and other environmental impacts. Okay. The other thing that the NHS is doing quite well is its NHS supplier roadmap that you might have come across. So this is a procurement policy. The NHS allocates about 10% weighting to sustainability, and so it preferentially procures from companies, from suppliers that are more environmentally sustainable. By 2028, it's going to actually demand companies to release carbon footprint data of individual products, which it then aims to use to preferentially purchase it at the level, product level. So that's stuff that's happening at the NHS, the health system level. Companies are starting to do stuff. So there are increasing regulatory and procurement reputational requirements for companies to act. And so we're seeing things like pharmaceutical companies embedding eco-design into products, switching to renewable energy, engaging their own suppliers, because we think 80,000 NHS suppliers, each company also has 50 to 100,000 suppliers. So it's a massive, tiers of suppliers. So companies are doing stuff. Is it at the scale that it needs to be? No. So that's where health systems and healthcare providers can come in, because what we use is what companies produce, right? So if we practice more efficient, more careful, less wasteful healthcare, then that has a massive impact on what happens at the company level. And so we spoke about prevention, promotion, efficient care, and also low carbon care. So there's a growing emphasis, for example, on prescribing practices. Do we need to prescribe all of these drugs? We're over-prescribing, we know that, and a lot of those drugs are going to waste. So can we implement systems where we are very careful with what medicine and what healthcare we deliver? Not saying that we stop prescribing altogether, but I think it's just, we really need to think about how we balance patient and planet in these systems. So I'll end it there, but supply chains are hugely complex and hugely important in this conversation, and it would be great to have some further conversations on this as we move on with the panel. Fantastic, Pete.
Thank you. Right, so rather in contrast with the previous speaker, I do have slides, so thankfully you don't have to look at me, or you won't have to look at me. I'm Pete Sudbury. I'm a doctor by training. I'm a lapsed psychiatrist. I have a degree in natural sciences from the other place. Then I saw the light, came here to do medicine. I also have an MBA from Oxford Brookes. Making me overqualified for any job I'm capable of doing. When somebody says, let's talk about health and climate, I automatically go to, yes, that's a good idea, and let's look at the big picture, the framing. And I thought there were two quotes I thought of immediately. The one attributed to Niels Bohr, which he actually says is a Danish maxim, that prediction is really difficult, particularly if it's about the future. And the other one is the rather menacing or disturbing quote from AR6, the 6th IPCC report: the decisions we make in this decade will have impacts immediately and for several thousand years. That's probably not been true since the middle of the Cold War, when things were getting hot. And there are things that I think we need to understand about the wider operating environment. Let's see if the... No? Okay. Who knows this chart? Okay. So I said it's the most important chart in human history because it tells you 9 ways in which you could crash all or a significant part of the only known habitable biosphere in the universe. Which I think probably makes it important. The green space in the middle, the green bit in the middle, is the safe operating space. That's where you would want to be if you wanted to hang around for a long time. And then there's different domains. The further out the segment goes, on a logarithmic scale, the worse out of whack things are. And the more purple it is, the more that is a really bad idea. There is a lot of purple on that chart. That's the first thing. The second thing is the top here, that's climate change. You could stop climate change tomorrow and still wipe out the biosphere in probably 30 years because of all the other things. I'm not going to go through all of them, but there are actually two categories of things here. So climate change, nitrogen and phosphorus pollution, ocean acidification, and novel entities. That's microplastics and forever chemicals and all the other junk that are in the biosphere that have never been there before. They're all aspects of pollution. And the other things, biosphere integrity, land system change, that's adverse changes as a distant result of land system change. And fresh water are all aspects of excessive consumption of resources, unsustainable consumption of resources. So the next slide tells us a little bit about what happens when you do that. And it's a model that was built in 1972. The Club of Rome and MIT got together to model the world economy using about 30 different factors in it. And they ran it forward. So let's start with the first one. The first one here, green is industrial output, purple is food, blue is population, yellow is resources, and orange is pollution. The colour changes when you get to the next one, but never mind. And as you can see, what happens is everything grows, and then in the about now, industrial output peaks, food peaks, and then they drop off very sharply, followed by a crash in population. The reason for that is you run out of resources. Okay, that's overconsumption. So they said, right, let's double resources and see what happens. This is business as usual too. So there's resources right up there. This time food is in yellow and resources are in purple. No idea why that swaps, but never mind. And you can see, same thing happens. Industrial output goes up and then falls, crashes, and so does food production. This time, it's because pollution gets you. In fact, there is a double whammy here because if you look, resources also run out towards the end of this century. Sorry, at the bottom here it's 1900 to 2100, so we are about here. And so you get the double whammy there. Anyone remember Monty Python, the Holy Grail, the knight who built the castle on the swamp? Well, this is the one that burned down, fell over, then sank into the swamp. That's that chart. At the bottom here are two ways of avoiding all or part of the bad bit. One is to innovate like crazy. And if you innovate really hard, then you can industrial output comes down, but not as badly. Food production has a bit of a wobble as pollution goes up, but then you get rid of pollution and you hold yourself in balance with resources. And then there's the sustainable world where you actually make active decisions to control population and industrial output, and therefore you control pollution earlier. Okay, so this is, now the fact is, these models, this one, proved to be uncannily accurate. It was completely online at the 20-year and 40-year reviews. And at the 50-year review, a lady called Gaia Harrington from KPMG found that you were somewhere between mostly this, but with a little bit of this innovation stuff. And I don't know, anybody been to the Innovation Zero conference in London? It's free to go and it is fantastic. You get there's a hall full at Olympia of people who are trying to crack this. And it's one of the inspiring things that you go to if you're a rather worried climate person. So we need to be careful about the narratives we use, because the narrative we default to is that climate change and everything else is like now but hotter. Now, the one thing it won't be is like now. The alternative narrative is civilizational collapse, and all the things between that. The fact is, one of the first things I learned as a psychiatrist was that human behaviour doesn't change. The best predictor of future behaviour is past behaviour, and our human behaviour right now is driving the car towards the cliff with the accelerator flat out. And so one would have to start preparing your health system for that kind of crash. What happens then? But also look at how it contributes to these. And indeed, previous speakers have done that very well. My view, I think you have to build a backup. If you start to, collapsology is a growing specialty, and it's absolutely fascinating because collapse is not a unitary thing. It happens in different ways in different places, and it happens in different things first. But one of its features is a loss of complexity, so that it becomes more difficult to do very complicated things if your supply chains are bombed to bits. Lord Deben actually said a few years ago that with climate change, we should be on a war footing because this will be like a war. And if you think about what happens in a war, most things go on and it's really boring, and every now and then someone tries to kill you. And the same thing with climate change. Every now and then you go on as usual, and every now and then a climate disaster hits you and tries to kill you. And all around the world, there are people waking up, finding themselves in their own version of hell on earth, completely unexpectedly. And for the next 30 years at least, that just keeps on ramping up. And so the idea that you can manage these vastly complex supply chains without them getting bombed out by a climate disaster becomes increasingly improbable. So my fallback would be think about the way they do things in Cuba. Cuba, they've got very strong primary care, very strong public health, really strong, and actually their health outcomes are really good and quite equitable too, quite unlike ours. You know, the richer people, like most of us in this room, the rich, well-educated people won't do us well, but the poorer people will do a lot better. That would be a good system to go to anyway. It's the one the NHS never adopts, because the National Health Service is actually, I think we know it's a national illness service, don't we? It does illness really well and it does health really badly. I'll stop there, I think, actually. Thank you.
Brilliant. Thank you so much. What informative and thought-provoking talks from each of our panellists. So I'd like to open up now to the floor for any kind of questions or comments.
I realise that this conversation has been framed largely about the NHS for people who talk specifically about healthcare systems, and I was wondering what we know about the role of private healthcare in terms of its own sustainability and what regulation there is for it, and how I have no idea what proportion of healthcare it accounts for in the UK. I don't know if it's significant or not.
It's a great question. Would anyone like to?
Is it 10%?
So I don't know what proportion. I know that it's an increasing proportion. I know that during COVID, they were relied upon in many ways to help with waiting lists. So there was a sort of NHS going into private healthcare, buying out a theatre for a period of time and then paying them. So there was an agreement there. And during those processes, and in the places where it's still ongoing, they fall under the NHS net zero commitment. And there is a little, in the net zero 2045, there is services procured outside of the ICT, which effectively is the use of private healthcare for delivering healthcare within the NHS. Having spoken to colleagues of mine that work within private, a lot of them saying that the private healthcare, whenever they find some kind of initiative that's helpful for sustainability, they're able to implement it fairly quickly. And they often say, well, it's because there's more money in the system, but I'm not convinced that that's the only thing. I think the NHS is a really big machinery with massive inertia and a lot of, well, we've tried that before mentality at times at least. And that can sometimes be a bit of a barrier, a bit of a hindrance to things that actually, well, it worked before, so we should try it again because actually it's better from a carbon footprint point of view, and it doesn't worsen healthcare. So we look to the private health sector in part for some of the evidence creation. But yeah, I don't know in terms of how they fall under the net zero commitment, because it being a legal requirement, I think that only applies to the public health service.
I'll try to just make a link with the previous panel. I think we tend to think about health as isolated from the environment, right? But I think we already made the point that we are not isolated to whatever happens in our built environment or access to nature and so on. Dr. Sudbury, they made a very good point about complexity, and I think talking about supply chains, there's an increasing role of resilience. So how we can make a complex organization to work on that more systemic approach on health, and at the same time reduce that complexity to work on prevention more at a local level in an environment rather than a centralized way, and to prevent illnesses deteriorating at the point that you need a more interventionist approach, a more costly, both in money and carbon and all resources. I guess this is about talking about complexity and resilience in our health systems, and more have a systemic approach.
When I was a junior doctor, which I think was a long time ago, it was a very long time ago actually, I remember being taught that the secret sauce for the NHS was primary care, because you got that very quick triage, and an awful lot of things could be dealt with in primary care, and if we strengthened primary care, it would do any better. But if anything, we haven't done that. It seems to me that nobody has gone. We know all the evidence says if you strengthen primary care, community early in intervention, and public health, you get better health outcomes. But nobody ever lost their job in healthcare commissioning for not commissioning primary care or mental health for that matter, or any community services. They lost their job for any waiting lists. Any waiting time. Now, any waiting times are actually a symptom of a failing system, but they bang on treating the symptom rather than the cause. And I think there is a problem with politicians. I can say that because I'm not a politician anymore, and anyway, I was only pretending when I was doing it, because it is really hard to make the right decisions when you know that you are going to get clobbered for it. But I do think a bold government who understood what they were doing would be saying, actually, these are the benchmarks we're going to look at. This is what we're going to look at. We're going to look at how we make people healthier, and we're going to measure it, and we're going to crow on about it. But don't hold your breath.
Amy, do you have any thoughts about the resilience part and supply chains?
Yeah, I mean, I think, well, I'll briefly talk about the resilience part, but then I also want to touch on complexity because it's such a complex topic. So when we think about resilience and supply chains, obviously there's the environmental impact of those supply chains, but we also know that they are impacted by environmental changes and crises themselves. So raw materials are going to become less common. Things like aluminium and lactase and things that pharmaceutical companies, for example, use in their products are going to become more costly. Supply chains are going to be disrupted by droughts, by floods, by extreme weather events. You would think in cold chain storage of drugs, which now you're sitting in extreme heat in countries that don't have cooling facilities. So that whole supply chain is going to be hit by climate change as well. And so when we think about resilience, we also need to think about how those supply chains adapt. And so there are conversations around onshoring and moving supply chains to more local regions. So NHS, for example, has a partnership with Novo Nordisk to create more sustainable and resilient cold chains for the insulin. So those sort of collaborative and, I guess, innovative ways of creating systems that are resilient is one aspect of it. And then you can also speak about access to medicines and shortages. And so coming to the complexity aspect, you have health systems that are trying to balance sustainability, cost, waiting lists, having access to all of these products. So it is hugely complex. But I think going back to your point, if you have people in charge who understand the goalpost, and the goalpost is to keep people healthy. It should be. It shouldn't be to treat illness, but we've almost shifted the goalpost. If we can get back to that, then I think a lot of these things just fall into place. Cost less. It's adaptation is easier, resilience is better, and people are healthier, and the environment is safer. So shifting that goalpost, and then obviously complexity needs people from a range of different backgrounds to engage in these issues as well, which is why we have interdisciplinary conversations like these, so that we can all try and tackle these wicked problems.
There's something not very obvious about resilience, that resilience and efficiency are actually opposed to each other. An efficient system has a single supplier and one supply chain, and that's brilliant. A resilient one has several. So our world economy, which is so complex that nobody understands it, but it is constructed around being as efficient as possible, and actually we need to reconstruct it as being much more resilient, which will be more expensive, so you will get less value. So everything that we have been doing for the last 30 years, well, longer than that, actually has been driving in the wrong direction very fast. And so we will find that the cost of things goes up and things are less available, because you have to do more work to keep the system as it is going.
And going back to those principles of more broadly of resilience and adaptation, Sara, you mentioned a bit about adaptation planning and how some of the data is helping us to potentially identify people who might be most at risk. I wondered if you wanted to come in.
Yeah, sure. And I think just to also kind of add to the previous point on complexity, I think I'm not a medic, but of course, in healthcare, there's this whole sort of iceberg concept where the people you're seeing in the clinic and in the hospitals is just the tip of the iceberg. There's a whole sort of general population at the back end. We're all here gathered to talk about sustainability, but actually what we're seeing is, the cost of living crisis and, the whole economy, at least in the UK context, is in recession, and the biggest impact is on, the two sectors of healthcare and education and care in general. And so although we're talking about sort of the impacts of sustainability, what we're seeing in practice is that the burden is being pushed. The economic burden as well is being pushed down to the community care, as well as down to the general public and the patient and the carers themselves. And I wonder if that's also something we need to keep in mind as we're thinking about the complexity when we think about sustainability, because sustainable practices are, as a mother, for example, of a child who's asthmatic, and he needs his 4 inhalers because he does go to 4 clubs and so on, when the GP is going to tell me that actually I can only dispense 2 because of the carbon footprint of his inhalers, that's also a burden down to the carer and the patient and so on, right? So there's layers of complexity, which is the economic costs and the sustainability costs and so on as well, right? I just wanted to make that point around that. But to your point, Louise, about, yes, indeed. So one of the studies that we're doing is about going out to talk to people, again, from sort of across the social fabric of the UK, and trying to understand the impacts on the person and the patient of the climatic changes that we're seeing. And in the UK context, although we do some work globally as well, it's more the flooding, and it's mostly the heat so far, and obviously the cold snaps as well. So the sorts of things that we've heard from the general public through public and patient engagement and so on is, I'm white, I'm a school teacher, I've been teaching for 30 years, and I cannot operate anymore in during heat waves. So what's going on with me? I obviously am not used to heat, and you have, for example, people who will say that, I'm a South Asian, I have a family history of diabetes, yet the tool that the doctor uses in the clinic to assess my conditions are not really designed for me. They're not even taking into account sort of my socio-demographics and all of the sorts of things that we heard from the panel earlier in the morning as well. And you can kind of piggyback on that, the whole sort of impact of climate as well. So it's a kind of a compound effect, but I think what these sort of studies are showing as well, and the literature is showing, is that, there are, if anything, climate is exacerbating and adding to existing and ever-increasing underlying health disparities, because there are people who, because climate has a role in, that people living in certain areas where the temperatures are higher, or living in certain areas where access to cooling is lower. Just thinking about heat, and of course, climate is a lot more. Goes a lot beyond heat to other sort of hazards as well. So it is a case of, at least those of us who are working in the kind of evidence generation space, to really to understand this side of things as well. Looking within our populations, who are the groups most at risk, and what are their risk factors, so that healthcare providers and policymakers can both be informed what sort of solutions will work as we move towards adaptation, which is inevitably what has to happen in some ways. Yeah,
that's really helpful. And I don't know, Søren, did you want to come in on that? I suppose that integration of environmental risk, if you like, in addition to the kind of health inequalities.
Yeah, so I think, and coming back to the question about systems, or the comment about systems, I think it's so, that's really where we need to act. And shifting the targets is also shifting what data we use. And we have an incredible amount of data being collected all the time. And it's shocking how little we use. And we have a lot of it. And I think your paper, Sara, looking at the ethnicities and how, depending on which data you use, you have different labels, you have different codes, and if you combine it all, you have a much richer data set, a much better way to disaggregate and look at your population in a more holistic way. And I think if we start getting better access to this, not just within a research framework, but within the health sector, we can start incorporating that differently. And OUH is doing a lot to this. So the data analytics team, they are creating a lot more data available through platforms that makes it immediately available for us to sit and look at, okay, well, this is our clinic population, what are they looking like, what are they coming through, where the non-attendance rates coming from, are there specific populations at risk? And that's the kind of data we need. That's the kind of data that can start helping shift and make the link between health inequity, sustainability as a whole, and trying to reach out to the population that instead would come in with an acute admission that would require a much more, fueling sort of hard cash, more resource, but also it's a missed opportunity because that's preventable in the first place.
Yeah.
Fantastic. Any further questions from the audience? One on the back row.
So my question is around how to incorporate the environmental impacts into the decision making. So for example, when we are recommending a new treatment to the NHS, shall we evaluate the environmental impact beyond the traditional cost effectiveness framework, for example? But if we want to evaluate that, how are we going to do it? Are we going to, for example, measure the environmental outcomes in the clinical trial beyond the treatment effectiveness? Or are we going to incorporate into the economic evaluation framework? Then how are we going to quantify that? Or are we going to just rely on the qualitative evidence just through the discussion with the stakeholders? And similarly, speaking of the use of real-world data to capture the health inequality, so are we also going to incorporate that into the decision making? Shall we ask the pharmaceutical companies to submit evidence not only limited to clinical trials, but also the long-term use of their treatments within a wider population? So how these things can be incorporated into the decision making? So there are lots of discussions around these topics, but I'm really interested in knowing what our panel are thinking around these areas.
Thank you. That's a really pertinent topical question, so thank you. I don't know, Amy, do you want to pick up on that?
Yeah, I can pick up on that. So there is a lot of work in this space. Well, there's a lot on single-use and reusable medical devices, and that's fairly straightforward because we know for the most part reusable is just better across a whole host of environmental impacts. Where things become more challenging product-wise is pharmaceuticals, mostly because we don't have the data, because that data sits behind pharmaceutical companies' proprietary information. There are efforts to try and get that data. So as I mentioned, the NHS supplier roadmap is going to require companies to release their product environmental data by 2028. Whether that happens or not is debatable, but that's the current goal. There's a lot of work around developing methodologies for measuring that environmental impact, because we actually just don't know how to measure carbon footprints of a lot of active pharmaceutical ingredients. We don't have the emissions factors. So there's work around methodology, there's work around incorporating it into procurement, and there's work around actually teaching medical practitioners how to use that data. Because it's all very well that we have it, but what do we do with it, right? And as you mentioned, we're balancing cost, clinical efficacy, side effects, contraindications. Now we must also balance environmental impact, and it can be quite challenging. And you also have to bear in mind that incorporating that environmental impact is only going to make sense if you have multiple drugs that are essentially doing the same thing and that have vastly different carbon footprints, which often they don't, right? So my gut is that we actually have to move away from all of this data and quantitative numbers around it, and actually just implement things that we know are going to have an impact already, right? So things like de-prescribing, reducing polypharmacy, using social prescribing, personalized medicine we've mentioned, and is the whole point of this event, right? So there are actions that I think we can take without knowing the perfect data. Also, we're never going to get the perfect data on the environmental impact of drugs. So I've used drugs as an example. The other thing that I'll just briefly mention is that people are also looking at the concept of patient care pathways and looking at decision making around that. So you're going to take a patient journey throughout healthcare and collect data on all of the environmental impacts from travel, infrastructure, products, etc., and try and create the most sustainable pathway around that. In theory, sounds amazing, but we know that patients have different healthcare journeys. So I think it's an interesting concept for thinking about decision making around sustainability, but there's a lot of work to be done to actually materialize that.
Can I pick up on that? Because I was going to ask a question about the service delivery model, because, for example, the consultant outpatient clinic has an awful lot of car journeys strapped to it with the patients coming in. Now, okay, you could do a void shift improve. When they're all EVs, it'll be fine. So you could put that in your chart, actually, as one of those things that happens. But for example, would a telemedicine first approach, or telemedicine at the GP surgery, or something like that, if you really thought about sustainability and sustainable journeys and not clogging Headington up with traffic heading for the JR2, would you actually rewrite your service delivery models?
I'm looking at Sara there because she does this.
There is absolutely some evidence that can help, but like all of this conversation, it's just not that straightforward.
No.
So we also know that people need to see their consultant.
No, it's okay. I'm
just bringing in these models for one purpose without thinking about everything else that's going on. There are real opportunities, but there's a lot around kind of video and telemedicine. If you're making really long car journeys, it can make a real difference. If it's kind of short commutes and things that you're taking out of the system, less so. It just depends so much on context. And a lot of that is around the digital health programs, But it's, we're heading this way. We need to think about it all.
But it's an interesting one. So there's one of the hand surgeons at OUH who's also very prominent within sustainability, and she made it effectively her outpatient clinic. She made it a patient-focused setup. Asked them whether they wanted to have it over the phone or via video conversation, or via car journey, and she found that the younger populations were happy to have it over the phone or via a video, whereas maybe some of the older populations were keener to come into clinic And through this intervention, through patient choice, it reduced the carbon footprint of that clinic space, and the throughput was much more efficient. And it's a really nice sort of case story of how, through patient choice, but with a deliberate sort of design, it became a much more efficient flow. And we are seeing, COVID has parts to do with this, a lot more use of telemedicine in our clinic space. But coming back to the point, if I may, about the choice, because I think it's a really important one, and I've asked economists this many times, health economists, who are so used to use the QALY, so the quality adjusted life years. And we get trained on this and drilled on this in medical school. You know, this is the measure that you use to decide whether or not an intervention is worth your money. And NICE relies on this to decide whether, you know, the cost per QALY is adequate in terms of the funds available. And of course, there's conversations if it goes outside the remit. So they have very clear guidance around this. But we don't have that. And for many reasons, we don't have that. And I think you outlined very clearly how it doesn't really fall within that. But the risk we have is that there'll be a push towards this. What is the carbon footprint per intervention that we will fund within the NHS? And I think that would be really high risk, because again, that takes it away from the patient and the sort of population focus that we, if we were to reset sustainability, we would rather have, as you mentioned.
Yeah, and I think just to come to that as well, we so often dichotomize these things. So it's patient versus planet, but that doesn't have to be the case. And I think we almost have to reframe it. And so when we think perhaps a carbon intensive intervention might be worse for the patient, is that the right word? So therefore we want to just do what's best for the patient. That's great. And often the carbon intensive intervention might be best for the patient and limit further experiences of healthcare and therefore downstream environmental impacts. So I think it's slightly more complicated than going at this single intervention, this is worse or better for the environment.
I can see we've got a few sort of burning comments at the back. Annika, do you want to come in? Maybe we'll have a few comments and then we'll come back.
We should not beat ourselves up too much, because remember that 25% of all the increase in emissions in the last 20 years has come from the top 1% of income earners in the world, and that's bugger all to do with healthcare. That's not them going to more clinics, I assure you.
Thanks very much. Annika Lucasson, Centre for Personalised Medicine. I wanted to pick up some of the comments that you were making about pharmaceuticals. I think that was really interesting, and being bad for the patient and planet, that contrast. We've been having amongst our group discussions about green inhalers, and very interesting how that has, from a public health perspective, green inhalers make a lot of sense, but that hasn't really trickled down into individual healthcare very well. And I think that highlights to me also this tension between public health and personalised medicine, and we need to get much better at bringing those two together. We've got these fantastic approaches in healthcare, but actually they don't really interact very much. And the example of green inhalers, I think, is a really nice one to consider there.
I think there was another comment on the, yes, yeah. Do you want to pass? No.
Yes, I agree with a lot has been said, especially like in the difficulties of quantifying and, like measuring the impacts, and how we don't want to be kind of narrowed in that kind of path in order to make decisions. But I was struck by also when you were presenting, Amy, and I agree with everything you were saying. But then I was thinking, you said, well, what we have to do is like changing our behaviors and our prescribing behaviors, our way to deliver healthcare. And you kept on talking about we. And I was thinking, like, who is this we? Because it's like who is taking kind of this responsibility, who has this agency to change the way we do things, or healthcare is provided, because I'm not a we, I guess, in this context.
Yeah, it's a really good point. I think I was probably referring to we being healthcare providers, because that's how I view myself. But I think you're absolutely right. Like, where does the responsibility for this lie? And so often you have health systems going, oh, supply chains need to do more, companies need to step up, and they do. And on the flip side, you have companies saying, well, we're just supplying what you're using, so you also need to step up. And then when you think about decarbonizing all these collaboratives, it often just becomes these shifting of responsibility and blame game. So I think absolutely, when we think about we have to think about the entire health system ecosystem and who the players are and how we can get everyone involved.
Give it to you. She had 100 pages.
That's fine. Thank you. This forum is titled "The Future, Low Carbon Future of Health and Care." I think we haven't talked much about care. For a local authority perspective, adult care is a significant proportion of our spending in supply chain and also part of our supply chain emissions. Maybe we can make some link, and I'll open to further discussions after this forum to collaborate further with academia and NHS and practitioners like yourselves on how to engage this sector.
Yeah. Our biggest residual for when we've got a net zero target by 2030, and the biggest residual to offset is staff travel, most of which is in care.
But I mean about scope, that's still between scope 3 operational.
Yeah.
Scope 3 to our contractors, adult care contractors such as the Order of St. John.
Yeah, no, I know, but even within the county council, its own envelope. Never mind on the supply chain. You're right. Care is a very big.
Would anyone else like to comment about social care?
I think there's a real link missing. I completely agree, and it's frustrating actually, because being in secondary or quaternary care with referrals that we come in sometimes, just having this sort of, we only have the hospital data, we only have the hospital notes, we don't have access to the rest unless they bring it, and it's really frustrating because I think that you miss the whole story. Often we see an end product of a very long journey, and we can manage it and treat it, but if you don't know the reason or the story that lies behind it, you're missing out a lot of points that may be more relevant than the acute illness that they're bringing. So yeah, it's a real frustration.
Thanks very much. Is this working? Yeah. Hi, I'm Rachel Stancliffe, and I'm the Director of the Centre for Sustainable Healthcare based here in Oxford. We're a charity. I just wanted to ask, I totally agree with complexity, resilience, also the urgency that Pete, you've kind of outlined here. Given that urgency, and given the IPC say that this is the decade that we have to make the difference, which is now 5 years left, does the panel think we're focused on the right things? What are the most urgent things that we need to do as a collective interdisciplinary group, and what's the role of research in that? Is research focusing on the right things?
Who would like to start? Søren, do you want to start?
I think personally, I think we got the focus wrong. I think there's been a lot of good steps, and the trajectory is right in many ways, but it's not fast enough. And I feel it's because of that acceptance of status quo that we're starting from where we are rather than looking upstream to the systemic barriers that lie within the system. And I guess it's coming back to the link with health inequity and the structural barriers that lie, that mean a lot of it is pushed downstream. And we see the issues coming up at a point where, had we gone in earlier, we could have had a huge impact. But we waited for a variety of reasons. There's so many pressures all the time. And within the NHS, there's real exhaustion and burnout, and the feeling of having to refocus, even if it's the right thing to do, will send a lot of shivers down spines, because we're just about getting to grips with what we're doing. So it's difficult because, as you're saying, the urgency is there, we have 5 years left, but actually if we were to retrain our focus and recenter sustainability in its true sense of the word, really embrace the broader terms of prevention and patient advocacy, that would be a real handbrake turn, and would take a lot of investment across many levels. So in terms of how we do that, I don't know. but I think we should, and I think research has a big role in this, and that's why it's really nice to see this kind of panel coming in where there's a bridging between, because actually research can become an advocacy role rather than trying to say, well, this is the objective truth. We can say, this is the objective truth and we have to do something about it.
Sara, do you want to comment?
Yeah, look, so I think a few points there, and at the risk of playing the devil's advocate, one of the sort of, I mean, there's a lot of climate forums that one goes to, and then one of the sort of global platforms that I happen to sort of participate in also is called the Planetary Health Alliance meeting, right? It's a coming together of multi-sectoral sort of global stakeholders from the humanitarian sector all the way through to academia, industry, government, legislators, what have you. And to Pete's point about, are we beating ourselves up too much? Because in those meetings, health and social does not feature. It's because, and there's a reason why, right? It's because it's not necessarily, this is not necessarily the sector that is driving the climate sort of the emissions that one needs to be focusing on if we are to kind of tackle. So when we're looking at those scary graphs and the wedges and those wedge shapes and all those sorts of things. So that's one thing to keep in mind. And I'm glad you mentioned it and you said that, look, there's, we have to kind of keep things within context. So we mustn't lose sight of the context. So that's one point. The other thing is within that, there's a lot. You say what next and how to. There's a lot that has been learned during the COVID-19 pandemic. So that was one of the silver linings, right? So we've learned how to do sort of telemedicine better and avoid those sort of, reduce some ways of reducing carbon footprint have been learned during the COVID pandemic. So we're talking a lot about carbon footprinting, but the other thing we saw in the pandemic was PPE, so pollution. So maybe there's other ways in which the healthcare system is indirectly harming the planet and then harming our health in turn, because what we put into the oceans and the landfills ultimately comes back to us, right? So maybe there's that holistic thinking that needs to be done around some of that, and I think all of that has made its way through to the NHS's sort of net zero report, the latest one, and so on, where they do talk about. I think that's something to be thinking, but that also involves a mindset shift almost, where we think about how we think about something being single use versus reuse, recycle, make the most out of it. And that is maybe where, those of us here in the UK can look towards the majority world to see other attitudes towards getting the most out of your one product and so on. But then again, coming back to the point that we are in the life-saving sector. So we shouldn't necessarily beat ourselves up too much about the fact that, we're providing anesthetics and so on, which are, made of plastic.
Really quite important.
Or what have you. So there's a lot of, I think, context. But I'll just, my final point about the place of research. I think there's a lot of effort, rightly so, on understanding and doing things around mitigation and just, net zero. There isn't necessarily enough that at least I've seen in the research space, in the health research space around resilience and adaptation. So that definitely is an opportunity. I know that funders and donors are also kind of interested in that and have identified that as a kind of a gap, which is where maybe research can focus a little bit, because we've talked about it. It's coming. It's happening, and we need to have health and care systems that are resilient and are able to produce those public advisory guidance for the heat waves, for the cold snaps, for the floods, and all the rest of it.
Really helpful reflections. Amy?
Yeah. So I think in an ideal world, what we really should be focusing is radically changing our society. And to come back to what you would suggest around donut economics, finding some ways to operate within the donut, that is probably too idealistic, unfortunately, to radically change our economic systems within the next 5 years. It's almost certainly not going to happen, unfortunately. So then what I think we have to do is focus on the actions that we can take within our personal spheres. And to go back to your point, you're right, healthcare as a proportion doesn't contribute heaps to greenhouse gas emissions. However, it does feel the burden of environmental crises, and it picks up all of the effects of other systems and sectors that have failed. And so we do have a role to play in that. And we actually have quite a good narrative to sell to advocate for change in the environment and in our societies. And so that's one point. You also mentioned that climate change is just one aspect of healthcare's impact. You mentioned PPE and waste. There's also pharmaceuticals that leak into our environment. We haven't spoken about that. That has massive impacts on our ecosystems, on antimicrobial resistance, on, so there, we actually have to play a role in making healthcare more sustainable, whether we think it has a large impact proportionately or not. And so what I would really like to focus on in healthcare is shifting the goal from treating illness, the National Illness Service, as you called it, to actually promoting and promoting health and preventing illness. That would really be my focus. And I think the role of research in this space, I mean, we've known for decades, centuries even, that prevention and promotion is the best way to go. But why are we not implementing it? So finding some way to bridge that gap from research to implementation would be really beneficial, I think.
Okay. Donut economics is not just a nice idea, it is the only way out of the closing jaws of the trap. Unless you institute something like donut economics and get back within planetary boundaries, you will crash. Overshoot is like bleeding. It stops in the end, and it stops either in a planned way or an unplanned way. And the unplanned way has very unfortunate consequences, which is probably the deaths of billions of people and the extinction of most of the species on Earth. So let's get serious about that. I kept this with me by accident, because that sustainable world thing, there are a very constrained number of ways of doing that. You cannot, because if the Earth overshoot day is in July, isn't it? So we are using Earth's resource about 1.8 times the rate it can replenish them. Half of that's fossil fuels. So that would be good. Just stop oil is a really, really good idea. But there was another slide that I'd put in. Gaia Harrington, who reviewed Limits to Growth in 2020, said, the sustainable world model, humanity has to let go of growth. It's not sort of, oh no, let's not, no, growth, you cannot have infinite growth on a finite planet. And the fact that we have managed to be fooled for years that you can divide 1 by infinity and not get anything other than naught is really quite extraordinary. And you need to move to resource efficiency, pollution abatement, and health and education. That is a world actually built around the human beings who live in it. We're talking, weren't we, earlier about being in people's lived lives. Our economies are nothing to do with making our lived lives better. Our economies are to do with making a very few people much wealthier. And 1% or actually 0.1% or even less of the population is effectively looting the resources of this planet for their own pleasure. And that is what needs to happen. And it's no use saying it's going to be difficult. You do the counterfactual on what it really is like to watch the planetary boundaries finally crash, and really you don't want to be there. And the majority of people in this room will be alive when that happens. So the question I asked when I got to the county council is, what would we need to do to crack climate change? Not what can we do, what is convenient to do, what is affordable, or even what is possible. And I said, if what we need to do turns out to be impossible, then we better redefine impossible, because failure is not an option. And I think we just need to do that, because otherwise we, our children, and everybody we care for are really going to have a horrible time. And that's us in one of the wealthiest countries on earth. Try being in the less wealthy ones, it'll be even worse, or they will go first. But what's that Churchill thing about people in a room with a tiger, each hoping the tiger will eat him last? That's the world I don't want to be in. There we are.
It's very optimistic.
Yeah, no, great. That's a great finish. But that's the only way out of the jaws of the trap.
More questions, comments?
Can I just ask Rachel? You're at the head of the CSH. She's been doing this for a long time. What do you think is the answer to your question, if you don't mind?
Sorry. Yeah. What? No, it's fine. What he said. No, obviously, this is what we need to do. And back to Amy's. Yes, we all do have to play the parts we can play. And some of those parts feel very small and insignificant. We need to work together better, always think about what assets we do have. I think there are, back to the first discussion about, top-down stuff, things that can be done at a system level, big things versus understanding individuals' parts within that. I think, things are very individualized in this country generally. And a lot of responsibility is put on individuals. And there are things that we can do at the system level that just are not that difficult, actually, and that we should be getting on with, whether they're done by councils or, at national level, or systems like the NHS that we can regulate and make rules. I mean, a really simple, when I go and talk to people in NHS trusts sometimes, it's just primary care. It's really simple things like, do you pay the same mileage for cyclists as you pay for people with cars? There was a different mileage rate given to people with bigger cars in the NHS until I don't know if that's still true. So you get paid more for driving a bigger. So there are, and the same back with, face-to-face versus digital appointments. I think face-to-face, the providers were being paid 260 quid or something for each one, and a digital one was being paid 80 quid. So the incentives need to, that kind of thing is a really simple thing to change. And there are so many things like that we can just do without actually affecting patient care. There are lots of other things that we know that we can do that actually improve patient care, back to Søren's point. And there is much better data use that we can make, triangulating different kinds of data to catch things earlier so that we don't have the numbers that we have coming in. So yes, working across all of these things. But yeah, I think let's do those easy things because, so you mentioned the net zero report, and the 5-year update's just been published today, literally. And it shows that, we're making really slow progress, unsurprisingly, on the supply chain, because it's really hard. It is happening, and there are lots of good things happening. But some of the good things that are happening are around anaesthetic gases and inhalers. So, there are things that clinicians are doing already that are making a real difference, and that patients can be involved with that are also making a difference. And we need to start with those.
I just wanted to kind of add, I guess, and maybe ask the panel, how can we communicate some of these things, as you say, are easier to do than others, but how can we communicate this better to patients and to the public? What methods can we use? How can we do this better? Because I feel that that's also a big gap in terms of actually us making meaningful steps towards climate action.
I think you talk about pollution and waste. We're trying to reduce pollution and waste, avoid climate action, avoid net zero. Talk about, because that's what that Rockstrom chart shows: pollution and waste.
Yeah, I guess for me it's also changing the narrative around how we formulate it. Often, I think almost always, it's related into how far you can drive in a car. Everything is related to how far you can drive in a car, which I think is all right because it's relatable. So, how the component of this is 57 kilos CO2 equivalent, which is the same as driving X amount in a car. And I think if we sort of change the way we talk about it, rather than always talking about it in the same way, about carbon footprints and this, that, and the other, but talking about it, how it impacts on communities, how it impacts on the broader population, then that might be more relatable. I think we've slipped away from being relatable and sort of understandable to becoming more scientific in our approach, and that's not useful.
Yeah, I think language and narrative are important, and every time we do our public and patient engagement sessions, where we're just sort of we shouldn't be, but we're surprised at how much patient and public and are us as well. So it's they have ideas. Everybody has ideas and voices, and we keep being surprised by how much of the discourse is enriched by co-creation and engagement and having people to bring their voices and ideas, because families have opinions, children have opinion on this, mothers have opinions on this, and so a lot of it is just bringing people together on the table, as we heard from the earlier panel as well, around transport and so on, and cracking it together. I don't think it's because there's a lack of ideas or intention. It's kind of just working it all out, it's one of those issues that I think in today's day and age, it's less of a communication challenge, and we see it all around us. We see in the media, people are feeling it. It's more about bringing everybody together and striking that balance and giving. I don't know how it's solved, but the agency has to be there. The agency for systems to bring in change, the agency as well for individuals to bring in change. So when they bring those ideas about how something can be done, they should also have the agency for that to be able to implement it in their everyday lives and so on.
I think it depends on what you're actually communicating here. So are you communicating the fact that environmental crises is going to have an impact on people's health? I think that's fairly obvious and most people buy into that. Or do you have a patient in front of you and you're offering them two different types of treatments and one is better for the environment than the other, and you're trying to get that point across? That's a slightly different conversation. And so you can, tell them that clinical efficacy is the same, blah, 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 and then that environmental impact is lower. Most people will probably buy into that as long as it also costs a similar price. But there have been studies that have shown that patients care more about cost, quality, and clinical efficacy than sustainability in those individual conversations. There is a body of research that has done work to convert environmental impacts of drugs into daily adjusted life years. So then you can sit with the patient in front of you and say, well, actually, this drug is going to reduce your morbidity and mortality by X, Y, Z. So that's actually in some ways a better way of convincing them that this is better for their health as well. But I think, to be honest with you, a lot of the action needs to happen upstream before it gets to when you're having those conversations with patients.
It's really helpful.
Everyone in this room probably lives their lives leading with the analytical bit of your brain. Actually, what's the right argument? What's the answer? What's the best? And the group of people so that's the sort of guardian reader mind, really, isn't it? And actually, certainly in politics, the people who feel disenfranchised and left out, they're not thinking like that. They're actually emotionally charlatans like Farage, liars like Farage, engage people through telling compelling lies that make them angry or upset or feel that they've been done over because they know they have. And somehow we need to start communicating with them. We need to communicate in a different way. We've got the Guardian readers. I said this in a post about the leadership for the Green Party. Zach Polanski has got it right. He's looking at how you communicate with those people who are just furious. They know that they've been done over. They know they aren't getting what they should in this society. And those are also, of course, the people who are hard to reach in healthcare too, because they've probably given up And they've probably had awful experiences because they can't get a GP appointment. They live in the poorest areas with the worst healthcare, and so on. And we need to find a way of communicating that isn't about, oh, it's about driving a car this far. It's about, somehow you need to talk to that emotional brain. I confess I am useless at that. I am completely analytical. This is not I do not have that chip on my motherboard at all, which is another reason why I stopped being, among the many reasons I stopped being a politician. But actually we need to get the people who are good at that and get them to write our leaflets and tell us how they say that, and then we'll be communicating actually with the people who need it the most, need the help, need the healthcare, and actually who will suffer the most from climate change and environmental destruction and the disintegration of society and all the other things we've discussed today.
So thank you so much, everyone, for all the audience participation. Thank you to our fantastic panelists. And I know there are many more conversations that are going to move forwards later on at drinks and the rest. So can you all join me in thanking our amazing panel? I'm now going to hand over, I think, to Sara, who's going to sum up.
I am, but Zahura, how are you getting on? I have 1 more minute. I'm just sending the... Perfect. I'll start talking. It's nice to meet you all. My name is Sara Briggs. If you don't know me, I'm one of the, until last week, was one of the research fellows at the Centre for Personalised Medicine. I was tasked with summing up. I think actually Rachel did quite a good job of summing up quite a lot of what we've discussed already and what needs to happen. But I think my key takeaways here are that, firstly, we need to think about the people that this is affecting and include them in the conversations. So we heard brilliant perspectives in that first panel on what that means within other non-health sort of sectors, and the importance of thinking about different people's perspectives right from the start and bringing those into the conversations that we're having. We had that quote from Jenny who said, who and how do you get the right voices to the table? And the quote from her family member about not being heard. And the language that we use and the importance of that, and having unifying language that reaches all the people that we need to reach and brings people together across sectors. We heard a bit from Lawrence and also from Amy more recently about the business sector and pharmaceuticals, and are they a force for good? I'm not sure we answered that question completely, and I'm not sure I'm convinced. But they certainly have a massive role to play in addressing the climate and environmental crisis. So ongoing conversations are definitely required. More latterly, we've talked about carbon footprints in healthcare, and are they even the right thing to be measuring? We've spoken about the importance and the wealth of data that we've got for addressing climate and health issues, and how we utilise that more effectively to support people who are going to feel these changes the hardest. And Soren's highlighted the importance of looking at inequalities. We've heard lots about the importance of prevention and health promotion, and having an NHS that targets wellness and not illness. And interestingly, I have recently, with some colleagues, completed some focus groups with members of the public looking at sustainability in the NHS. And they very much spoke about wellness and making the NHS a service that, kept people well, and also spoke about the NHS as having a big role in prevention rather than that being something that sat outside it. So that really rang true to some of the conversations I'd been having. Zahura, are you good to go? So Zahura, who is multi-talented, so not only has been illustrating our discussions, but also is part of the sustainability team at the Trust, is going to do a bit of we've got too many.
A lot of USB sticks.
Yeah.
Is that one out?
Does it matter? Yeah.
Yes. Yeah.
Jess, do you want to come and double check?
Don't press the red button.
Oh, great. Do you mind? Can you do that one? And I'll do a little bit.
I will let her sum up, and then I'll just say a few last words.
While you guys
So while you've all been talking, I have been busy drawing away. And this is some of the things I'm drawing. So I do work for Oxford University Hospital Trust. I'm the carbon programme manager there on a day-to-day basis. And so a lot of the things you're talking about were extremely interesting to me. And I spent most of my time thinking about the thorny issue of staff travel, which is our largest area of emissions our second largest area of emissions at the Trust, and the only area that's rising. So transport is a very, very big issue for us. But what we talked about today, I'm just going to go through very quickly. So in the centre, you've got this interdisciplinary perspectives with these kind of everything connected, everything all mixed up together, and somebody kind of all within touching distance of that. We're starting with the kind of difficulty, climate change is so big, and biodiversity loss, and how wicked the problems are. I wanted to capture the idea that there's like double impacts of things. So as something else becomes worse, that sends something else that's good down. You know, this idea that everything is interrelated, and there's lots of correlations and causations. I did a little bit on green infrastructure there, and how many fantastic outcomes there are, and green enough in poorest areas having the biggest impact. In the idea that do no harm is no longer enough. And then there was a whole interesting piece on the lived experience and visible and invisible problems and emotional labour. And we talked a bit about that, and how to reconcile all of that into policy and evidence, but the importance of acknowledging it. I personally, my favourite drawing I think of the day is the people on the bikes having very, very different experiences. So some people loving it, some people whose backs are killing them, and some people feeling really unsafe. But they're all technically on the same bike on the same route, but if having very, very different feelings. And then I picked up Pete's quote there of policymakers focus on the number of deaths, because it is very countable. And then you'll all get copies of this afterwards. This is the second one. So it's a little bit gappy because I was drawing up until the very last minute. Where are we and where do we need to be? So hopefully that title is clear enough. Moving from a kind of problematic red, dark arrows and facing backwards, moving towards more green arrows. People who are very visually literate might notice that on the left-hand side of the first picture, there was a big dark cloud over someone's head, and on the right-hand side of the second picture, there's this sunshine and and positive weather. So together, that will show a kind of hopefully a nice progression. So what did I really like? The one in the centre is this idea that preventative care, climate impacts, and health inequality is all like one completely interlinked triangle that you can look at from any angle, and it's all completely interrelated. You can't. It's like an Escher triangle. I did a bit on the supply chain and how much of the supply chain is the NHS footprint, but also just how vulnerable it is to systems collapse. And you've got a horseshoe crab over there, which is a great little thing to draw. The overemphasis on carbon footprint and biodiversity being missing with the waves they're coming over and sort of kind of crashing onto the supply chain, which is kind of, I'm going to maybe develop that a little bit when I've got a little bit more time. And so everything's in kind of symmetry from efficiency to resilience with the hands, and from 2020 to 2040. So it's supposed to be a relatively symmetrical picture. So there you are.
Thank you so much. It's absolutely amazing. I love seeing that sort of come to life with colour and imagery. I might put it on my wall. Thank you, Sara. So just finally to say, when we sort of conceived of this event, we were in part motivated by an awareness of lots of people, both within the university, but also across the region, who were doing pieces of work on sustainable healthcare and climate and health without necessarily us all being linked together. And you alluded to, the sort of absence of work in the care sector and interest in doing work further on that. And we would absolutely love to try and generate some sort of ongoing network out of this event where, we can come together for future research and implementation projects and, try and drive systems change in some way, which might be big aim. But there are lots of brilliant minds around here with lots of ambition and all working towards the same goal, really. And so do put your name down on the mailing list. We do have email addresses from sign-ups, so we'll maybe send an email out afterwards and just check if people are happy to come to be put on the mailing list on the basis of that. If there's interest, we may try and plan something and some sort of get together in the future, but that can sort of be can sort of emerge over time. We hope you'll stick around for drinks to have more conversations about where work might be taken forwards. I should have mentioned also there's obviously opportunity for coming together for teaching as well, and lots of work to try and integrate more of this work within all courses at the university, and I suspect also at other local educational establishments. So it would be great to do more on that as well. So thank you all for coming. Thank you for such interesting and stimulating conversations. I really hope to see all of you again soon and enjoy drinks. Thank you.